Now moving on to anaemia, we commence once more with a practical example. I've just had this blood result through on a 50-year-old lady who has been tired and breathless with a haemoglobin of 74 and an MCV of 69. I will go in and check the ferritin, but can I start iron now?
Ignoring the hen's teeth differentials of inherited sideroblastic anemia and lead poisoning, the likely causes of a microcytic anemia is iron deficiency, thalassemia, or anemia of chronic disease. Anemia of chronic disease only tends to cause a mild microcytosis and is usually normocytic, and the haemoglobin never falls below 80. In this case, it's either going to be iron deficiency or thalassemia. As thalassemia is inherited, and if the patient has had a normal MCV in the past, then this will only be iron deficiency. Also, it would be very unusual for thalassemia to present this late and with this degree of anemia. I would say you only need a ferritin to confirm iron deficiency if you're concerned about thalassemia. I would start on oral iron now and then investigate why the patient has become iron deficient. Iron is found in a wide range of food, both animal and vegetable, so dietary iron deficiency is only found in people with quite restrictive diets. Celiac serology should be performed. The most common cause of iron deficiency is bleeding, and you only need to lose 3 ml of blood a day to exceed your absorptive capacity. I would check a urine dip for blood and, if negative, refer for GI investigations.
She is symptomatic of her anaemia. Would it be worth transfusing her?
The risks of transfusions are considerable. Also, it's costly and a limited resource. For any hematinic deficiency, the anemia has came on gradually, meaning the body has had time to accommodate. Also, after replacing the missing vitamin or iron, the bone marrow will start producing extra red cells almost immediately. And after a few days, the haemoglobin may be increasing by as much as 10 grams per litre. I would say only in cases where there is cardiovascular compromise should transfusion be used. If the haemoglobin is very low, then IV iron can be used, which starts working quicker than oral iron. It can also be used in patients who cannot tolerate oral iron. For example, we had a lady last week presenting with a haemoglobin of 42, and with IV iron alone, it was 90 grams the following week and normal 2 weeks later.
Would you say, Mark, could this be a mixture of iron deficiency and anemia of chronic disease as she has mild rheumatoid arthritis?
That's always a possibility. Checking ESR and CRP will give you an idea of the degree of inflammation. If these are normal, then it's unlikely that much of the anemia is due to chronic disease. Ferritin is an acute phase reactant and therefore is going to be raised if the ESR and CRP are also up. In these cases, if the ferritin is below 100, then there's likely to be some degree of iron deficiency.
Thanks, Mark. I also recently saw a 48-year-old gentleman who drinks to excess and has a haemoglobin of 98 and an MCV of 102. Is this all due to the alcohol?
Most likely, alcohol can cause a macrocytic anemia and often a thrombocytopenia and neutropenia as well. This is either by direct toxic effect on the bone marrow or splenomegaly secondary to portal hypertension. However, it's important to exclude other causes. The differential for a macrocytosis is B12 or folate deficiency, hypothyroidism, obviously not in this case but possibly pregnancy, liver disease, drugs and certain bone marrow problems. A reticulocytosis can also cause a mild macrocytosis if there's increased red cell turnover. Common drugs to cause a macrocytosis is the chemotherapy drugs and the antiepileptics.
His folate is only 3.5. Might that be causing it as well?
It's not unusual for people who drink to excess to be short of folate, but unfortunately both B12 and folate levels are very variable and often difficult to interpret. Because giving B12 and folate is pretty harmless, a trial or replacement can help determine if there's true deficiency, as you would expect to see an improvement in the MCV. Remember never to start folic acid before you have ensured they are B12 replete.
Okay, thanks. Can I just clarify, what are the main sources of B12 and folate?
Folic acid is found in fresh fruit and vegetables and in some fortified foods. It is, however, rapidly broken down by cooking, so those people who have a poor diet, folate deficiency is not uncommon. Because folate goes into making DNA, you can also get folate deficient if there's increased cellular turnover, for example in pregnancy and in hemolytic anemia. Folate is rapidly absorbed throughout the gut and only celiac or Crohn's will give you malabsorption. B12 is only found in animal products including eggs and milk and some fortified food. Therefore, strict vegans will become B12 deficient. In the stomach, B12 is bound by intrinsic factor and then it's absorbed in the terminal ileum. So people who have had gastrectomies or bypass operations or have had their terminal ileum removed will need lifelong replacement. Celiac, Crohn's and ulcerative colitis may all cause reduced levels. Probably the most common cause of B12 deficiency is pernicious anemia. This is an autoimmune disorder which destroys the parietal cells which excrete the intrinsic factor. About 80% of people with pernicious anemia will have intrinsic factor antibodies. Therefore, those people with B12 deficiency and no GI symptoms and have a negative intrinsic factor antibodies are likely to have pernicious anemia and should be treated as such.
Okay, but we haven't mentioned normocytic anemia.
This really includes everything else. Renal dysfunction is a common cause as the kidneys excrete erythropoietin. Immunoglobulin should be checked to exclude myeloma. A drug history should be taken. A Coombs test to exclude hemolysis should be performed, and consideration should be made for inherited anemias if the anemia presents in childhood or a young adult.
Thanks very much for those explanations, Mark. In summary, what would be the key messages?
I think the most important point with regards to anemia and how to investigate it is looking at the MCV, so to determine whether the patient has a macrocytic anemia, normocytic anemia, or a microcytic anemia, and that can guide what further investigations that patient needs. The other important part is that vitamin-induced anemias usually come on very slowly, and therefore the body has time to adapt. Therefore, transfusion should only be used as a last resort.